Hi, Mohammed Al-Mala here. I wanted to share with you this cataract surgery case of a patient with a small pupil. You can tell here the pupil is about 4 millimeters in size. We've already started the surgery. We've made the first incision and we've put in preservative-free lidocaine into the anterior chamber. And now we're going to insert a viscoelastic into the anterior chamber. And you can see shortly here as we do this, that was preservative-free epi before that. As we do inject viscoelastic, the pupil dilates further. So that's the visco dilation. We can see here we've got about a 4.5, 5 millimeter pupil. And here I use the 0.12 forceps to stabilize the globe. We do this for the keratome incision as well as to do the capsulorhexis. And by stabilizing the globe in this way, it significantly decreases the stress of performing the capsulorhexis part of the surgery. I go in first with a cystotome, and with one motion, we raise the flap. And we can see here we're already starting to get a hint of iris prolapse just by doing that. So I decompress the anterior chamber. I let out some of the viscoelastic. I do put some visco right at the wound to see if that can help prevent further prolapse, but it doesn't seem to be very effective. We can see we're still getting some iris prolapse here. So I use my capsulorhexis forceps to depress on the posterior lip of the wound, and that lets more viscoelastic out of the anterior chamber, further decompresses the chamber, decreases the chance that iris prolapse will occur. And then I put in some more visco right there, just right at the wound. So we'll see here how effective that is in terms of preventing any further iris prolapse. Well, so far so good. We're doing the capsulorhexis and we're not afraid to go under the pupillary margin here. I've found that it's rare in these cases for the capsule to run out or to get a radial tear. You can see that the anterior chamber is fairly hypotenuse. We can see those folds in the cornea, but we're able to continue and maintain a successful capsulorhexis. The next step is going to be hydrodissection, and in a case like this, we're going to be concerned again about iris prolapse. So I tent up the capsule. We're going to attempt a cortical cleaving hydrodissection. We see a nice fluid wave there, and we didn't get any iris prolapse. The one advantage of the cortical cleaving hydrodissection is that you just do one fluid wave. There's less BSS inserted into the eye. But if you do get iris prolapse, you want to stop. You want to decompress the anterior chamber again and deal with the iris prolapse before proceeding any further. So now we're going to do Phacoemulsification. I do a stop and chop I do a Phaco chop technique. So we're going to go into the nucleus here with the Phaco probe. And I'm watching this case for the first time here with you. And we do a vertical chop. A horizontal chop. We've got a decent crack so far. Got some rotation here. Okay, so it does rotate here. And what I'm probably going to do is do another chop. Got a fairly dense lens. And then at this point, I am going to start removing quadrants. Sometimes I'll rotate the nucleus again and chop the second heminucleus before starting to remove. But here it looks like I'm already starting to aspirate and emulsify the nuclear material. You can see the iris actually is quite floppy here. But nonetheless, with the Phaco chop technique, it's really whenever you have a small pupil, I find that the Phaco chop technique makes doing small pupil cases easier. So the case is progressing nicely. We're emulsifying out the second piece. This is a completely unedited video, and I've started just showing unedited videos. I think you learn from the times when you see me do something, or maybe it's not quite as smooth and polished as other edited videos. And I hope that this is, able to see something and learn something from this case. So we've removed the heminucleus here. You can see it doesn't look like there's really much cortex behind that. We're going to now rotate the remaining heminucleus here, and continue to phaco aspirate. The rotation here is not the best, but nonetheless it is moving and it is rotating. Once I'm able to aspirate with the phaco, I'll probably try and chop this again. Or maybe I'll just try and take it all out as one piece. We're using the Alcon Centurion peristaltic system. And I did chop that, I did use second instrument to chop that. And now I use my second instrument, I hold it behind the nuclear material to keep the posterior capsular back. And we see there's really not too much cortical material here, which is nice. I'm using the phaco probe just to pick up pieces here that are still in the anterior chamber. And we do see some cortical strands there floating around. But nonetheless, overall, I'm happy. We've been able to take out the entire nuclear material. This is a Terry squeegee capsular polisher. I'm going to use this to polish the posterior capsule centrally. So this is injecting viscoelastic Provisc. Rather than injecting straight into the bag, I've gotten to the habit now of injecting both to the right and to the left to remove any remaining nuclear material that could be hiding in the anterior chamber angle. And I've found since I started doing this, really trying to minimize the chance of having any remaining lens material. So here we have injected the intraocular lens. This is a single piece acrylic IOL, an Alcon lens, an Acrosoft Clarion lens. And now we use my IA to put the IOL into the capsular bag. And now we use IA to remove any remaining cortical material, of which there is some, and so actually quite a bit. And so we're going to use, the nice thing about doing this technique is if you do have, you've already polished the posterior capsule centrally, and now you can, with the IOL in place, protecting and keeping the posterior capsular bag back, you can then use IA to remove any remaining cortical material that's present peripherally. I will probably use the Charvel, yes, here it is, to retract the iris and look for any remaining cortical material that could be hiding behind the iris there and in the in the capsular fornix. And it looks like it looks pretty good here. Okay, so I'm fairly happy with that. I may be getting another instrument here, perhaps a Connor wand, to further retract the iris. And I do see some cortical material there. Okay, so we got that out. And you can see the pupil here has really come down quite a bit. We're between 3 and 4 millimeters at this point. There may be a little bit of cortex still left there. Or really may not be much of anything at all. In any case, so yeah, really down to 3 millimeter pupil at this point. Once again, I'm injecting BSS into the anterior chamber angle to make sure there's no retained nuclear material. And then we're going to irrigate the wound. I irrigate the main incision first, and then I irrigate the paracentesis. And then want to check to make sure the anterior chamber is adequately formed. In any case, I wanted to share another small pupil case with you. This is how I generally approach patients with small pupils. I still do use Malyugin rings if the pupil is extremely small, but if with viscodilation I'm able to get about 4 to 5 millimeters in size, and I typically do the surgery without using another instrument to retract the iris. In any case, thank you for your attention. I hope you enjoyed this case. Please leave any comments, questions, how you do it, whether you feel that this is whether you feel this, whether you like this technique or whether you prefer different techniques for your surgery. Thank you very much. I hope you found it useful.